audible?
Are we audible? Good morning.
Yes, ma'am. Good morning, ma'am.
Good morning, ma'am. Yes, ma'am. You are audible.
Yes, ma'am. So, Miss Ma'am, we are going to.
Yeah, please start.
Yes. So, you are going to start this session of this national webinar. So, a very good morning to all of you. Today, we are here to celebrate the World Breastfeeding Week 2022. And it's my proud privilege to welcome our Additional Secretary and Mission Director, Ms. Rolly Singh Ma'am, and our Joint Secretary, RCH, Dr. Ashok Babuji, and all the mission directors from the states and UTs to this very important webinar on the occasion of World Breastfeeding Week 2022. I also welcome the chair of the technical session, the moderator, and the eminent speakers, Director NIN, Dr. R. Hemalata, eminent experts from the academia, Professor Harish Chalan, Professor Kumuta, Professor Aarti Maria, and it's my pleasure to welcome the other panelists, Dr. Ramesh Kumar, President Indian Academy of Pediatrics, Dr. Santa Kumari, President FOXY, Dr. Arun Gupta, Coordinator BPNI, and Dr. Nigel Rollins from WHO headquarters, and Dr. Antarjami Das from Save the Children as panelists in this. My heartiest welcome to all the states and UT participants and my other colleagues from the Ministry of Health as well. So as you are all aware, every year we celebrate World Breastfeeding Week from 1st to 7th August. And this year we are focusing on strengthening the capacity of the actors who have to protect, promote, and support breastfeeding across different levels of the system. So all the healthcare providers, including the nursing nursing cadre, so they are all here and the theme of this year to step up for breastfeeding, educate, and support. So this webinar aims at the knowledge sharing for further strengthening the efforts for improvement of breastfeeding in the country, especially early initiation of breastfeeding. So I welcome you again, and with no further delay, I request our Joint Secretary, Dr. P. Ashok Babu, sir, to kindly deliver his opening remarks. And one point, just I want to inform also that this event is also being streamed live to YouTube. So thank you all, and over to you, sir.
Rolly Singh Madam, dear panelists.
Now it's working.
Yeah. Am I audible, Dr. Sheila Dev?
Yes, sir.
Yeah. Respected Rolly Singh Madam, Dr. Sheila Dev, all the participants who have joined across the state nodal officers, and panelists. On this World Breastfeeding Day week, when we are celebrating in India, I would like to see 2-3 things here. The breastfeeding is not just nutrition, it is much more beyond that. The recent figures, when we see it, yes, in the NFHS 5, there is an enhanced participation or enhanced community level participation for increasing the breastfeeding, especially the exclusive breastfeeding. But when we see the early initiation, etc., yes, there are issues. This webinar throws light on various issues from the panelists, what is happening, what best can be done, not only to the babies, to the mothers and their health, etc. Thank you for giving me this opportunity. Now I will pass on to Dr. Sheila Dev to carry on with the sessions. Thank you. Dr. Dev, it is muted.
Thank you, sir, for your opening remarks. And now I request our Additional Secretary and Mission Director, Rolly Singh ma'am, to deliver her keynote address. Over to you, ma'am.
Good morning, everyone. I would like to welcome all my colleagues from the states and UTs, the MDs who have joined, eminent experts who are here for the discussions, representatives from Indian Academy of Pediatrics, the Federation of Obstetric and Gynecological Societies of India, FOXY, Breastfeeding Promotion Network of India, representative from the development partners like WHO and Save the Children. I also welcome the state nodal officers who are here from the states and the UTs for this very critical issue of breastfeeding, how to promote breastfeeding practices on the occasion of World Breastfeeding Week 2022. Joint Secretary Ashok Babu is also here, and our program in charge is also here, Dr. Sheila Deb. So as we are all aware, we are all experts who are sitting here, and there are people from the field as well. You are all aware of the criticality of the first 1,000 days of breastfeeding and what bearing it has on the health, future health of the child, the immunity of the child. And these first 1,000 days determine the developmental milestones that the child achieves in the years to come. So we cannot overemphasize the importance of this issue. The only challenge is how to ensure that all mothers across the spectrum of income groups, across educational attainments are able to imbibe this information and actually utilize this to provide that necessary input at the time of the first few months of the child. So there's been a lot of work that has taken place in introducing optimal breastfeeding practices, and the early initiation of breastfeeding is one of the most critical challenges that we are facing, because I think there is a challenge of communicating the information to the last mile. So I would really like all the officials and the experts who are here today to put their heads together and work out a strategy. It essentially has to be a very effective communication strategy. It has to be, working with the community health workers in the field. It has to be a lot of synergy with the state nodal officers. And I would request the MD NHMs who are listening today, and even the state nodal officers who are listening today, to please ensure that this is an intervention that is taken up seriously. Many a times we think that these are these are normal practices, and things will happen in due course of time, but we are losing critical time if we do not see the importance of this intervention at the right moment. And this week, I think, is a reiteration of the importance that the world accords to this issue. And I would again request all the participants here to put their heads together and come forward with effective strategies for ensuring that this happens. Because the importance of early initiation of breastfeeding has been established, as well as the fact that the continuation of keeping the child on exclusive breastfeeding practices has also been established. We are aware that as per the NFHS 5, 2019-20, the rates of early initiation of breastfeeding and exclusive breastfeeding for 6 months are 41.8% and 63.7% respectively. So while we have made a lot of progress on exclusive breastfeeding for 6 months, as the data shows, the early initiation of breastfeeding still continues to be a challenge. And while we can be happy about the improvement on the exclusive breastfeeding, that the critical first the first few hours, or the first few, just after delivery, those minutes need not be lost just by lack of awareness or lack of effort at the delivery center. So how do we engage with how do we bring this as a part of behavior change, not only among the community, but also our health service providers, who should be nudging the mother towards this at the absolute first instance. So we have to work towards this. There's some more data that I would like to share. The early initiation of breastfeeding has wide interstate variations, as we are all aware, and from 21.5% in Jharkhand to 78.8% in Meghalaya. So the top 5 state UTs are Meghalaya 79%, Lakshadweep 76%, Odisha 69%, Kerala 67%, Chandigarh 64%. Bottom 5 states and UTs are Jharkhand 22%, Uttar Pradesh 24%, Dadra, Nagar Haveli and Daman and Diu 26%, Bihar 31% and Chhattisgarh 32%. And the exclusive breastfeeding ranges from 80.3% in Chhattisgarh to mere 28.3% in Sikkim. So the top 5 states here, I would like to just mention them and congratulate them, are Chhattisgarh 80%, Dadra Nagar Haveli and Daman Diu 79%, Jharkhand 76%, Madhya Pradesh 74%, Odisha 73%. Bottom 5 states are Sikkim, which is 28%, Meghalaya 43%, Nagaland 43%, Uttarakhand and West Bengal at 53%. So it's a matter of concern that there is an increase in cesarean sections as well, from 17.6% in NFHS 4 to 21.25% in NFHS 5. So and most of these health deliveries that are cesarean section are happening in the private health facilities. I mean, at least 47.4% are in the private health facilities also. So we are even the government health facilities are equally culpable. So we are all aware that these deliveries are associated with delay in that early initiation of breastfeeding. So how do we overcome that, that barrier when the mother and child are separated after deliveries, after a cesarean section, and how do we inculcate this practice across? So that's why we would look for support from organizations like Foxy and the other networks that are here, to ensure that this gets disseminated and actually brought into practice, and especially in the private facilities where the cesareans are taking place. And so the Mother's Absolute Affection Program, we are all aware of. This has also been launched across states and UTs since 2016, and it's a comprehensive set of activities on protection, promotion, and support of breastfeeding and child feeding at the community and the facility levels. And so the efforts of this MA program, we need to reiterate them once again, and we need to revitalize this entire program and build an enabling environment for breastfeeding through awareness generation. So like I said, the key is awareness, and the key is also awareness amongst our service providers, both in the public as well as the private sphere. So I believe the theme this year for the breastfeeding World Breastfeeding Week is step up for breastfeeding, educate and support. So this provides us the opportunity to fill the gaps and give a thrust to the efforts made so far to strengthen and improve early initiation of breastfeeding practices. However, the promotional activity should not be linked to this week only, and rather it should be an year-round effort, and the effort should not be flagging after this week is over. So basic thing is information, communication, both to the mothers, and some behavior change at the service delivery level, at the service delivery facility, among our healthcare providers and the nurses who are attending to the mother and the child. How quickly they are able to imbibe this information and to convert it into practice, that is a challenge, and that's where our public health systems should get their act together and start working towards it. Lot of our nutritional issues, a lot of our issues related to growth, like stunting and wasting, can be addressed if this very simple intervention is introduced at early on. And there are a lot of I believe there are a lot of community level barriers. There are a lot of taboos that are associated with the early initiation, that those need to be broken. So an effective communication strategy is the key, and I would urge all the state who have joined. I'm not able to see here how many state participants are there, but I hope that they're listening and they're going to take this forward seriously. So I would like to again wish everyone all the best for this workshop. I can see Dr. Aarti Maria there, and there are so many other experts who have joined. I would congratulate and welcome all of you once again, and let's hope that these efforts fructify into something meaningful towards health of both the child and the mother involved. Thank you very much.
Thank you so much, madam, for your kind remarks and very knowledgeable and guidance. And so now, sir, with the permission of Chair, Madam, I am going to present the breastfeeding trends in India, a very brief presentation. And so we have got the improvements and what are the gaps. So, so thanks again. Next.
We can't see the slides, Dr. Sheila Dev.
You can't see the slides?
Yeah.
Oh. Okay.
Sheila, we can see actually.
I can see the slide.
Okay.
Can
you
put
see
them
now?
No, I can see the screen only with Dr. Shraddha Verma written on it. I don't know why.
We can see.
Oh, all right, then continue. I mean, I can't see it. That's what I
can see.
Okay. Come. Just I request just bear with us for a few minutes. Let us try.
You can start the slideshow now. Maybe if it's full screen, it will be visible. It's not yet full screen. Is there a problem? Are you not able to share, Dr. Dev?
But we can see, ma'am.
Yeah, I can see as well. I mean,
Dr. Sheila Dev, you may continue. Your voice is not audible. He's in mute.
I should mute herself.
Ma'am, you are muted, Dr. Sheila Dev. That's why perhaps we can't hear you. Yeah.
So, am I audible now?
Yes. Can you go back to the first
ma'am.
slide and begin?
Yes, ma'am.
Yes.
You can start from the beginning.
Yes. So, let's start. चला जाएगा. चलो.
Ma'am, can you please make it full screen?
It is not used full screen.
No, ma'am.
ये अच्छा सबका वहाँ से हो रहा है क्या? देखो. हमें तो full screen दिख रहा है. ये वाला क्या है? इसको करो. ये वाला ना बीच में आया.
Dr. Sheila, you have to go to the first slide.
Yes. First से भी रखो. चले जाओ first slide. Stop sharing कर दो वहाँ पे दबा. आपका. Yes. हो रहा है ना? इसको stop sharing कर दो. नहीं तो दो जर्नलिस्ट ना. Yes, sound
वो नहीं हो रहा है मुमताज, जब से वही ट्राई कर रही हूँ मैं.
इसमें इसको छोटा करते हैं, इसकी मिनिमाइज नहीं कर सकते, आप शुरू कर देंगे. So, so very sorry for the interruption. So I am going to present the brief overview of the breastfeeding trends in India, and the improvements and the gaps as we have seen in NFHS 5. Next one. Is the slide moving? Yes. So here is the comprehensive status of breastfeeding and other IVC practices in India. So here the data is from NFHS 4 and NFHS 5. So as you can see that there has been an improvement in the prerectal feeding. That is the improvement in the prerectal feeding status. That is, it has actually decreased. Earlier in NFHS 4, it was 21%, and now it is 15.5%. And the timely initiation of complementary feeding has also improved a little bit, from 42% to around 46%. And there has been an increase in the exclusive breastfeeding also. And so it was earlier 55% around, and now it is around 64%. However, the early institution breastfeeding is actually stagnant. But when we look into the figure of the institutional births, so it is around, it has but the institutional birth is now, it is as per NFHS 5, it is around 89%. So there is a huge gap, as Madam has already pointed out, that we need to work in this area. But one interesting feature is that when we look into the institutional breastfeeding within 24 hours of birth, it is 87%. So from 41.8% to 87%, and this also that there is actually and quite a doubling of the initiation of breastfeeding within 1 day actually. And but as also the madam has said, there is large inter and interstate variations, and there is a problem in the cesarean section deliveries, as in the private sector, where around 38% of the deliveries are happening there. Around 21% of the deliveries are happening, 47.4% of deliveries are happening through cesarean section, whereas in public health facilities, it is 14.3%, the cesarean section delivery rate among the total deliveries. And in the NFHS 5 has also shown improvement in in all these the other areas like in exclusive breastfeeding rate. Next. So another interesting observation regarding the exclusive breastfeeding, as per the NFHS 5 report, what we see that the median duration of exclusive breastfeeding that has increased from 2.9 months in NFHS 4 to 3.9 months in NFHS 5. That is 1 month has increased actually. That means 50% of the infants, their exclusive breastfeeding has been increased into another 1 month. And the median duration of any breastfeeding has also increased from 29.6 months to 32.1 months. That is around 4 months increase in this any breastfeeding rate. And it has also been observed that children in rural areas are breastfed longer. Here the median duration is 33.5 months. Whereas their counterparts in the urban areas, they have their median duration is 25.8 months. So the children who are breastfeeding within 1 hour, this is a trend since NFHS 1 till NFHS 5. So there has been a steady increase in the in this early initiation of breastfeeding. And what we can see, that this is also again interesting, because we always think that the breastfeeding is better in the rural areas, but for early initiation of breastfeeding, the urban areas have shown better performance than the rural areas. Next. So here, this is the state and UT wise status of early initiation of breastfeeding. So as the madam has already said, that here we have huge state variations, and Jharkhand at one extreme and Meghalaya at the other extreme. So so this is a cause of concern, and it is also interesting to see that the NFHS 4 and 5 has shown that some states who were performing whose performance was not so good earlier, they are performing very well. On the other hand, those states who are performing well, they have shown a decrease. Like Sikkim, it is almost halved. Earlier it was 67%, and now it is 33%. And Assam has also shown a quite a major decline from 64% to 49%. And similarly, Dadra Nagar Haveli and Chhattisgarh, they have also shown a quite big decline from 50 to 26% and 47 to 32% respectively. So here these are the cause of concern. So we need to look into the factors what are they actually precipitating this situation. So here is the this is a percentage change in the early insertion breastfeeding rates. As I have already said, that some of the states like Andhra Pradesh and Chandigarh, Jammu Kashmir, Lakshadweep, Meghalaya, Delhi, Punjab, Uttarakhand, and West Bengal. These are the states and UTs who have shown actually a major increase in the early initial breastfeeding rates. But this stand still at the national level for this early initiation, because some other states have shown a major fall, like Dadra Nagar Haveli and Sikkim. Sikkim has the highest fall. It is a reduction in the 33.5%. So the Chandigarh's achievement in 30% achievement, there's actually, it has been neutralized. And that's why we are having a stagnant early institutional breastfeeding rate. And here is a picture, there's a picture of the institutional delivery rate versus early institutional breastfeeding. So here at the extreme right, we can see that Meghalaya and Nagaland, they are in these two states, the early initiation of breastfeeding rate is actually higher than the institutional delivery rate. So it is the institutional delivery rate in Meghalaya is 58%, and in Nagaland it is 46%. However, the early institutional breastfeeding rate is 79% and 58% respectively. So, that it can show that it is actually showing us that it is institutional delivery, in spite of having lesser institutional delivery rate, lower institutional delivery rate. Actually, the early institutional breastfeeding it can be raised actually, and so maybe it is we are presuming that the community sensitization and the local practices, those are actually in favor of early initiation of breastfeeding. And this is now the status, the trend of exclusive breastfeeding rate at the level. So here we can see that in exclusive breastfeeding, the rural areas of the country, they are actually in a better state than the urban areas. So next. So these are the few interesting observations as per the NFHS 5. Oh, sorry. So this the exclusive breastfeeding rate. This is the state-wise and UT-wise status of exclusive breastfeeding rates across the country. Here also almost as the same words are applicable for the exclusive breastfeeding rates also. States have shown decline, and some of the states have shown a very good performance in the NHS 5. So the interesting observations as for NHS 5 for mainly this early institutional breastfeeding and the exclusive breastfeeding rates. In a summarily, you can say that the early institutional breastfeeding has wide interstate variations, and only states in which more than 2/3 of the children are breastfed within 1 hour of birth are Odisha, Kerala, Lakshadweep, and Meghalaya. And timely initiation of breastfeeding is particularly low for women with no for home deliveries and for births delivered by a guy. So here are the areas where we need to work further. And prelactal feeding ranges from a minimum of 3% of children in Lakshadweep to a maximum of 31%, that is 10 times, the 31% of children in Chandigarh and Nagaland. But obviously, this was actually reduced from the NHS 4 level for this two states and UTs like Chandigarh and Nagaland. Another interesting means this is a cause of concern that the increasing that is about the increasing cesarean section rate, and this may be linked to the low possibility of breastfeeding within 1 hour of birth. So we need more evidence generation in this area. And the rate of cesarean section deliveries has increased from 17% in the NHS 4 to 22% in NHS 5, and they are particularly common in private sector, and in the public sector it is 14%, as I have already pointed out. And it is the cesarean sections are also observed to be more common among the first births, which is around 28% of the primaries actually they're delivering by cesarean section, and it is higher in the urban than in the rural areas. Next. So thank you all. Thank you all for bearing for this the inconvenience caused due to some technical issues. And so I end here with a saying as of our Honorable Prime Minister Narendra Modi ji, that health of the mothers will determine the health of our children, and health of the children will determine the health of our tomorrow. Thank you all. So next, I request our the Dr. Hemalata, the Director NIN, and Dr. Professor Dharish Chelani, HOD, and from the Neonatology Department of the Safdarjung Hospital to come in as chair and moderator of the panel discussion. So I am handing over to them this to go forward.
Thank you, Dr. Sheila. Thank you for giving this opportunity. So you have ended your speech with the health of mother will determine the health of child, and health of the child will determine the health of the future. Very rightly said so. I would like to add here, health of our children and mother will also not only determine the health of future, but also the health of the planet. When our food is healthy, we are healthy. And when our food is healthy, definitely our planet is also going to be healthy. It is the sustainable food that takes care of our health and also of our planet health. And of all the sustainable foods, breast milk is the most sustainable feeding that a mother can offer to her child. Because if she doesn't breastfeed and resorts to formula milk, 1 kg of formula milk produced results in 5 kg equivalent production of CO2. This is just one example I have given, but many other parameters are there, like hospitalization, which can also contribute to planet health. Anyway, coming back to the panel discussion, now it will be on how to improve early initiation of breastfeeding and further strengthening exclusive breastfeeding rates. And here we have one talk on integrated approach for successful initiation of breastfeeding at health facility level by Dr. Nigel Rollins from WHO. And we have experts like Professor Kumuda Jayaraman and Professor Aarti Maria. And also we have representatives from IAP, Indian Academy of Pediatrics, and FOXY. Then we also have Breastfeeding Protection Network India, BPNI, and we also have experts and representatives from Save the Children India. So with these few words, I would like to request Professor Harish Chelani to conduct and moderate the panel discussion. Thank you.
Thank you, Dr. Hemlata. It's always a pleasure, and you have already set the stage, highlighting the importance of this. And despite the rise in the institution delivery rates, across the country, though now we are reaching in some of the states close to 80 or 85, or some of the states 90% of the institution deliveries. But sadly, as per the NFHS data, as Madam has also shown, the first hour, the rates are around 51 or 52%, which can certainly be improved with the support and cooperation of all the healthcare providers who are working for this. But certainly there are some areas which also needs to be addressed to make the care more family centered approach, using that approach. And especially it is important when I look at it, being in the newborn care for so many years, the one group which is a large group is those babies who are low birth weight babies. And secondly, the another is those babies who are born by cesarean section. These are the another group of those babies which require the support from the healthcare providers. So without wasting on that, we have got very eminent people, and we are lucky to have Dr. Nigel with us. I have listened to him and we also working with him. And welcome, Dr. Nigel. You would be speaking on integrated approach for successful initiation of breastfeeding at health facility level. So over to you. We will request you to put light on this subjects, and then we will have the further discussion on the other areas also. So over to you, Dr. Nigel.
Thanks indeed there, Harish, and nice to see you again. And thank you. First of all, I would just like to share my thanks for the invitation to participate today. And it's great to see this whole event happening. So thank you to everybody, Dr. Sheila Deb, but really everybody within the Ministry of Health and Family Welfare for the effort and commitment that happens around these types of webinars. And I'm wondering whether I could share one or two slides, and I will, I think I possibly need permission from or some of your technical team to help me to do that. But if not, then I'll just keep on going, because I know, Harish, that time is relatively short.
So Nigel, I think you have got the permission because they told me to the panelists they will be giving it. But again, I'll request Dr. Sheila Dev to please make you the administrator. I mean, if
yes,
yeah,
the
ma'am,
permission
please.
has permission has already been provided.
Yeah.
That's as per our knowledge.
Nigel, so
But
maybe you
are
can.
you getting any problem in uploading the PPT?
I think it's just come on now, so that's great.
No, madam, it is not
just
showing
sharing this
access.
Okay.
Yeah, Dr. Sheila, it's not showing for me also. So yeah.
It's starting to
now
share
it's
the
there,
content.
now it's there.
Yes, it's coming. It's coming. Yes.
I think it's coming through now.
Yeah, Nigel, it's there actually. You
Yes,
can
it's
make
there.
it in the slideshow.
Great.
Yes,
So
it's there.
I've only got a few slides, but I think there's maybe one or two things that I just wanted to highlight using the slides. So the first question I think that we've got to ask ourselves, we heard a very nice presentation of the epidemiology and the changes in trends around breastfeeding in India from Dr. Verma. So thank you for that. But I suppose with this particular focus on early initiation, you've got to ask, why is this so important in its own right? And the very simple answer is that early initiation of breastfeeding reduces mortality, and especially neonatal mortality. And this is knowledge and evidence that we have actually derived, very substantially from India. And I just want to share one bit of information. This was an analysis published in the Lancet in 2015. It was an analysis of close on 100,000 infants from Ghana, India, and Tanzania. And when the researchers looked at this, and they looked at the neonatal mortality, that's mortality in the first 28 days, and they took the children or the infants who had been initiated on breastfeeding within the first hour, and they looked at the mortality in other infants. In the infants who started breastfeeding only after 2 hours, there was a 40% increase in neonatal mortality. And this rose to almost 80% increased mortality if breastfeeding was delayed until 24 hours. Now, Dr. Verma and Harish both made reference to specific challenges about the low birth weight and cesarean section, and those are very true. But fundamentally, we need to remember and realize that early initiation translates directly to survival. And it happens probably through two ways. First of all, we know that early initiation is extremely important for establishing exclusive breastfeeding. And exclusive breastfeeding, as we've heard, makes a difference to all of child survival and also to development. But independent of the effect on exclusive breastfeeding, early initiation also reduces neonatal mortality directly. We don't fully understand all the reasons why, but it does. So I think as we all think about the challenge of early initiation, we've got to remember that it's not just a statistic, it's not just a metric, or because it increases exclusive breastfeeding, it directly impacts on early neonatal mortality. So the question is, how do we go about integrating and increasing early initiation through an integrated approach? And I think given the time that we have available today, I really just want to focus on this one issue of the baby-friendly hospital initiative, something that many of you will know. And there we see within BFHI, the number 4 in terms of critical policy and practices. And here we see it saying, facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. So it really begs the question for all of us, why do we invest the time and effort? Because our time and effort needs to be reflected in policies and resources. Well, the simple message is, first of all, Where BFHI is established, we see higher rates of early initiation and exclusive breastfeeding. So fundamentally, it provides the platform and the starting point, both for reducing mortality and exclusive breastfeeding. The question is, as Harish was saying, about integration. When it is part of a comprehensive package that we see in Baby Friendly, it then becomes part of the health system. It becomes the standard by which the health system delivers care. It becomes what is expected, and it allows us to collect information and data. For the individual woman and mother, it means that early initiation is not just seen as a standalone individual event, but it becomes part of the continuum of promotion and support for breastfeeding from before delivery in antenatal care to what happens in the immediate peripartum period, and also the support that is then provided later on to support establishing exclusive breastfeeding. But the details of this, I think we see a little bit in some of the data from Dr. Verma. We saw that there were big variations in the data from India, from 28% to or 21% up to 78%. And those numbers tell us that there is a huge variability within the country, and therefore probably huge challenges. Mothers who sometimes move between facility from their home to other facilities at the time of birth represents a real challenge in that mobility. So unless you have an established health systems approach where integration is part of just simply the routine standard care, you can have excellence and high support within one facility, but maybe not available somewhere else. And so these tell us that BFHI needs to become a standard across all facilities within a state or across the country. Unless we see BFHI as the standard, then we are going to run into the problems of staff moving from one facility to another and different standards of care being delivered, mothers going from one area to another and receiving different standards of care. So I think BFHI, we don't have the time to go through it in detail. It really represents the integrated continuum approach that is all needed. I really just want to finish with one other point, Harish. And this was, I think, the role that is often not spoken about, and it's about leadership. And I was really interested to read the pledge that is part of the effort of the ministry this year, because I had actually thought about this issue about leadership before seeing the pledge. As program managers, as facility coordinators, as representatives at state level, only if we have confidence and certainty about the importance of an intervention, and that's why I started by saying that early initiation means improved survival, and we've got to believe that and have confidence in that. Then we have the commitment to that intervention, to the resources, to the time and effort, to developing that strategy, including the communication that was mentioned earlier. But I think we shouldn't underestimate the importance of leadership as we go forward. Colleagues and the people on the front line need to have the direction and the support and the confidence themselves. And I think that really starts with the leadership setting the example at the very beginning. So Harish, I could go on for hours, as you know.
I know.
I want to thank you indeed for the opportunity, and I'll hand it back to you now. Over.
Thank you, Nigel. I think you have really come out with the very important that it does affect the mortality, and we need to do right the uninterrupted skin to skin contact, and we must develop the standard as you rightly mentioned in the health system, so that the same message passes at every health facility. And another important thing which you highlighted should be a continuum of the care right from the antenatal period and beyond discharge, and even in the linkage between the facility and the community. So Nigel will come back actually, and now we have got people from the professional bodies, and we have got Dr. Arun Gupta, who is the coordinator of the BPNI, and we have also people from the Indian Academy of Pediatrics, Foxy. So what I have thought, actually we'll have 2 minutes quick comments for the start actually, uh, and then we will take the movements forward actually. So over to you, Dr. Arun. uh, uh, Nigel mentioned about the role of the BPNI, and I know you had been a strong advocate for this, and you are doing a great job actually in the country. In fact, really admire your way of working. So initial quick 2 minutes, what would like to say the role of the BPNI in improving the rates, and especially the babies who are maximum of our attention, small or sick babies. Over to you.
Thank you, Harish, and thank you, Ministry of Health, for inviting me. I won't take much time in the formalities. And very quickly, I think the role of BPNI for 30 years we have been working, and our essential role has been to advocate for the policy development as well as the development of the training programs which make the staff competent. So these are the couple of things, and of late, I would very quickly jump on to the baby-friendly hospital initiative, which Nigel very nicely explained. We have termed it now in last 2 years as a breastfeeding friendly, to get into more specific that we are helping mothers with breastfeeding. So BPNI has, under the Ministry of Health and WHO, developed the tools which you were also part of the technical advisory group for uh, you know, indicators for implementation as well as assessment of the hospitals in terms of getting the. This is the first time that I think such a tool has been developed, which includes outcome indicators like early initiation of breastfeeding and skin to skin contact. So we have developed those tools. I can explain it better when I have more time. Yeah.
Arun, I will just take it quickly. Next question to you itself, that uh, we have been advocating, but there are some operational issues which are continuing at the facilities.
Yeah.
So can you highlight next, I mean, in 1 or 2 minutes, the key operational issues of the hindrance,
Okay.
of the breastfeeding rates within 1 hour?
Yeah. The major operational issue is that the program does not address the private sector. So there is no guideline, no notification, nothing that will say to the private sector that you have to implement 10 steps. So I think that is one of the, neither the lactation management guideline, neither MA program, there is no specific indication for private sector. So that is one. Second, I would also suggest that the training program which was adopted by MA program 5 years back was developed for ANMs. So it doesn't address the healthcare staff actually, and what is needed within the hospital facility. So we have developed that also now, and we are using it in the private sector program. I would say that this competence comes only with that training. Ministry of Health is training people within the same period of time. I think we can offer the training program should be changed to health system rather than the earlier program was for the field workers actually, because it was developed for ANMs. So that is the second operational thing. Third is that there has been a lot of concern about use of formula, as Dr. Hemlata also mentioned. Now, that is something which mothers and women have been demanding, that there should be a consent, a decision making process should be incorporated during antenatal period, which comes as a part of the integrated point which Nigel mentioned. So a decision making, if a mother chooses to give formula feeding, consent may be recorded during pregnancy rather than every mother which comes to give a birth, whether normal or cesarean section, because it is quite possible and to feed a mother on breastfeeding, feed a baby on breastfeeding after cesarean section. We have seen it wherever there is a competence staff, it is possible. Over to you.
Thanks, Dr. Arun. I think highlighting, you touched a very important point of the private sector. And let me tell you, 60% of the care has been provided by the private sector. So we can't, ignore that sector.
Yes.
I think Dr. Shanta Kumari, she is the president, Foxy. And ma'am, welcome. And we would like to move to you. You are the important person inside the labor room. And we talk about the allowing the companion in the labor room, so that the somebody there should be to hold the baby onto mom's chest, because it has been often seen that in the government sector, or when there is a lack of staff, mother is exhausted. I mean, who to support the baby onto mother's chest? And even delivery tables, they should be in such a way that so that it is more comfortable for the mother and the baby. There should be side railing so that there should not be any fall. I mean, so Dr. Shanta Kumari, can you highlight on the issues of that, and also how, as a Foxy president, you look to improve these rates or to improve the these care? Over to you, ma'am. Dr. Shanta Kumari, are you connected with us? Anybody from the Indian Academy of Pediatrics? Because I can't see the name.
Dr. Ramesh Kumar is here. You can see his name on the.
Dr. Ramesh Kumar is here.
Okay, let me. Dr. Ramesh. Dr. Ramesh, can I put the same question as because the care is towards the, both government as well as the private sector. So how you feel as an, from the Indian Academy of Pediatrics, we can help to achieve this, target, or improving the rates in the, right in the labor room. Dr. Ramesh,
Dr. Chelani, Dr. Ramesh was there. We have observed earlier, but now in the list I cannot see the
okay.
participants.
So maybe Dr. Kumuda, you are around? Dr. Kumuda,
I am there, sir.
Okay, Dr. Kumuda, we'll move to you, because you had been the looking after the small and sick babies, and you have been also working closely for the training of the doctors and nurses. The one group which was there, small and sick babies, and Nigel also mentioned that there has to be uninterrupted skin to skin care. So what are your views on how to achieve this? In the labor room, is there any need to change the policy? What should we plan to do? Over to you, Dr. Kumada.
Sir, thank you, sir. I thank Madam also for giving me this opportunity. A very valid question, sir. So to start initiation of breastfeeding, the first act of skin to skin contact, especially for low birth weight babies, is it happening as it should happen? It is not happening, sir. So there are so many reservations among the people who are in the labor room. First, they are worried about the weight. If a baby is stable, especially those babies like 1500 to 1800, they do not need any resuscitation. They can be with the mother in the labor room, and also they can be shifted to the postnatal ward along with the mother. Only where they need is continuous close observation. Though, like having said that, current SNCO guideline for admission policy says children less than 1800. So I think in the admission protocol policy itself for SNCO guideline or training period, I think we have to modify this statement now between 1500 to 1800, where we can have babies with a mother if they are stable, but they need monitoring. And again, the another answer for this could be having like NBSUs need not be shifted to SNCUs, more working of the NBSUs, which is not currently happening. That is number one. And also establishment of mother and newborn units, MNCUs. I think in Tamil Nadu, we have just started one only in Institute of Obstetrics, where we could shift these babies who could be looked after in the mother and the newborn ward, and more monitoring can be done. But the people are very worried in shifting these babies to the postnatal ward. Their reservation is lack of staff and lack of monitoring, sir. So unless we make postnatal ward and rounds a mandate and 24 hours monitoring facility, unless we produce there in the form of HR who are trained and they are available, then it is very difficult to initiate this early skin to skin contact, and early initiation keep mother and baby together. Otherwise, they tend to go to the SNCUs or NICUs where separation happens. That is number one point. And number two, even if you are shifting sick babies to the SNCU who may need some respiratory support and much more interventions, the first thing we fail to do is expression of breast milk, sir. This is one thing. We always tend to do respiratory support, shock correction, and all those things. At the same time, equal importance to be given for expression of milk soon after birth. And studies have shown that if you start expressing by 1 hour, like Sir Dr. Nigel said, like within 1 hour, the mortality is so much reduced. But milk expression and getting that colostrum to the baby, either in the form of colostrum swabbing or minimal parenteral nutrition, that is minimal enteral feeding. So that point is one thing which it is picking up, but I don't think it has not gone to that stage. Though we always insist on this in the facility-based newborn training, but that part has to take. That's the second thing. And number three is kangaroo mother care, sir. See, kangaroo mother care, like getting the baby and the mother together as early as possible. Like you have proved that IKMC is possible. And also babies who are on respiratory support can be given to mother for kangaroo mother care. But unfortunately, that point across all the SNCUs, though it is improving, including in my state, but whether we have reached the optimal stage of kangaroo mother care implementation in its true form, immediate, early, prolonged, and continuous KMC. Even achieving ours has definitely shown us that milk supply moves. Getting the mother and the baby together as much as possible, increasing our KMC hours to 12 hours in a day. And also there, we should allow the family, sir. For all this, getting the mother for KMC, getting the mother for milk expression, another important drawback as a policy we have is third day, fourth day, mother is well, she is discharged. She is not given any postnatal bed, including in a government hospital. Most of the time, she is made to wait in the verandas, corridors. I've seen even in Delhi, in my own state, like which we are trying to correct, they're all in the corridors having a bed there and lying down. So I think we have to give them a dedicated place in the facility. This has to come from Ministry of Health, saying it is not only the bed. Tamil Nadu gives a bed for mother as long as she wants to stay, but still diet is not provided. See, after the maternal discharge, diet is not given to her. So getting the diet food for her to stay, unless she is available in the facility for longer period, her milk expression, her being together in the nursery and promoting, getting the mother and the baby together for early breastfeeding also is very difficult. So these, I think, as a policy, we have to get it. Policy one for admission policy into the SNCU can be less than 800, 1800 with no problems with the mother. And second, allowing the mother to stay in the facility, providing her a bed and a diet. Then only she can come for milk expression anytime into the nursery. And third things are still, all the SNCUs do not other mothers all the time. They say there is a visiting time, visiting policy, all those things are there. She should have free access to the nursery 24 hours. This policy has to percolate across all the SNCUs, not only in public sector, in private sector. Private sector, they discharge, mothers are sent home, and they come in sometime express once or twice a day, and that milk is used, and later other milk is being used. So this is another important thing I think we have to take care of.
Thank you, Dr. Kumita. I think you have highlighted very key, important, pertinent issues, that there are some stable babies who are just for assisted feeding. They are unnecessarily there inside the NICU, and there must be a respectful care for the mother, providing their bed and respectfully keeping them together. I think these are the very important and crucial. In the government guidelines, there is clear thing that family must be allowed to come, inside the SNCUs. But I think, as Nigel and Arun also mentioned, there needs to be a leadership that, these babies must be brought closer to the mother. Mother should be allowed freely to come inside the SNCU. These are some of the operational issues where we healthcare provider can, there is a policy of allowing, but I think as a healthcare provider, we should encourage to come to allow the mother to come inside. I will now move. Thanks, Dr. Kumita. I might, if the time permits, I'll come to you again. I will quickly now move to Dr. Aarti. Dr. Aarti, you have worked a lot on the family-centered care approach, which Dr. Kumita also mentioned, and uh, with your efforts, the family members are brought inside. And there is another challenge which I feel which you should touch upon, because you have got a lot of work on that. There are around cesarean rates are gone up actually, also both in the government as well as in the private sector. And these are the babies where, once the baby's cesarean is done, baby is kept into the one corner till the mother's stitches and other things are being cared. I know there is a challenge, but you have been able to overcome these challenges, I know. Can you highlight those obstacles, how you overcame those, so that, we get benefited from your experience? Over to you, Aarti.
Thank you very much, Dr. Chilani. And I want to thank Ministry of Health for allowing me to be, it's an honor to be part of this esteemed group. Okay, straight coming to that, but I think, Dr. Chalani, do you want me to address that why this first sacred hour, why it's called the first golden hour? Would you like me to elaborate on that?
Because, Aarti, because now time is only next 10 minutes, so I thought if you can touch the cesarean sections first,
all right.
And if the time permits,
Yeah,
because I have to, wind up by one. Yeah, over to you.
So cesarean is a particular challenge, skin to skin as such, providing uninterrupted skin to skin contact after birth in a vaginal delivery itself has been a challenge at places, and what to say about the cesarean section. And when we actually started, the fact that 70%, at some places 60, 50, 70% deliveries are happening by cesareans, that means if we are not able to impact or touch this group in terms of initiation of early breastfeeding, so simply because it's not, people consider it's not feasible or it's not doable, that means we are leaving this huge chunk with an likely adverse impact on the neonatal mortality. And if we are able to cover this, maybe this sudden, there'll be a big surge in the numbers that we are wanting to increase in the NFHS data about increasing the early initiation of breastfeeding and skin to skin contact. So how did we do it? We did it way back in 2016, and this practice continues in our hospital. So there were a lot of challenges, lot of iterative, PDSA cycles. We did it in form of a QI, sort of a QI. It was a major QI, quality improvement initiative. And we initially started with doing some sensitization sessions, which were really needed. And this needed to come right from the top. So we held an internal hospital meeting. Actually, we called for a meeting with multidisciplinary, like OBG colleagues, the anesthetist colleagues, and the pediatric colleagues, to create a sensitivity session, sensitization session, and tell them actually why this first hour, why it's so critical. We have people turn around and told us, what is the big deal? Why this can't wait? Why can't you do it when the mother is out of the OT? And maybe a few hours later, you could do the same thing. How does it really matter? But then understanding the science and the biological part behind the skin to skin contact, and within the first hour, which is most critical, rightly called the golden hour, I think that making them understand, and that it indeed is a life-saving strategy, that made people turn around, think twice about it, and we had to explain the physiological, biological basis and the science behind it. So it was a huge challenge, and still remains, to uh, to change the mindset and the behavior. So that was number one. But by and by, and showing and persisting with it, with a leadership, a dedicated leadership on the top. And this is a, thanklessly, I would say, repetitive, the sensitizations, perseverance, and continued, persistence is really required before we can think, because there'll be change of staff, people's motivation levels go down, there are operational problems, there are logistic problems, so people get bogged down, and then they say, okay, it's not possible. Another problem was people started misunderstanding the importance and the whole process. People started doing it for 5 minutes, and they would say, do it in a ritualistic manner, and they would think that it's done. So skin to skin, they have done. You ask them, and I started putting it in the file that, you please note the skin to skin was provided, and they would write yes. But when I actually checked with the mother, I realized it was put for 5 minutes, the baby was put 5 minutes, whereas it should be, the baby should be put for 1 hour. So those kind of things. So you keep working on it, improving it, and seeing the challenges wherever. And then the fact that there is no policy, just like we have to have a breastfeeding policy, we have to have antibiotic policy. Similarly, we should have a skin to skin care providing policy, with adequately displayed in the labor rooms, at the OTs. Talk to the nurses over there, talk to each and every person who matters. You have to sensitize not only from the top, but also from the bottom, which means the sulab workers, the aya workers, the people who are porting these babies. You have to create an, not only the sensitization at the provider side, but also at the client side. So the mothers should be aware. There should be a demand generation, that this is a standard of care. They should demand. It's their right, and very well they should expect it, and it should be delivered. Then there are challenges about working place, working space in an OT. The operating field is small. The anesthetist is at the head end, and the obstetricians are on either side of the mother. So it was extremely difficult to convince them and say, then you may be breaching the asepsis protocols by the process of coming. But we ensured each and everything, primarily the do no harm in the first place, and then be able to do the skin to skin contact. And then people needed clarity about the procedure and skill. So in this regard, we have actually brought in leadership at the top and extreme importance of communication, as I think Nigel mentioned very importantly in his last slide. Both these things are critical. In the same process, if regarding the same process, we've actually achieved it. It's almost universally happening. Of course, there are stray instances, and we keep chasing it like a, reaching perfection goal. And we have developed an audio-visual video showing and illustrating how it can be done in cesarean, the skin to skin. And we have also developed the written protocol and policy guidelines about it. Thank you.
Arti, can you share the link in the chat box so that people can be benefited from those
I will
videos?
try. Yes,
Because
yes.
the time is less. But I will move quickly to Dr. Dash from the Save the Children. Are you there, Dr. Dash? Yeah.
Yes, sir, I'm there.
So,
Sorry.
there is a lot actually which Nigel also mentioned about the communication and especially, and Aarti just mentioned about the demand generation. So, how do you think that, at the community level, we can increase the demand generation, or how that part, the involvement of the family, or how to improve the communication strategy as such? How do you look uh, these things can be done? Over to
Yeah.
you, Doctor.
Yes, sir. Sure. Thank you, Dr. Harris, for giving me this opportunity. You have rightly said that, this problem is mostly behavioral in, nature. So accepting for the early initiation, which is happening, one time in the hospital, I'm just now extending this, issue to, maintaining exclusive breastfeeding for 6 months and maintaining it and continuing for at least, 2 years is even more difficult because it needs a recurrent and a long-term, home-based, and a very nuanced nature of practices that can make it more challenging than something which is a one-time service-dependent behavior. So community and cultural traditions they have a very strong influence on the breastfeeding decision and practice, and we need to create a new normal where mothers are being supported in their decisions to breastfeed at home, at work, and in the community. Evidence shows that mothers, they have 2.5 times more likelihood to breastfeed or to continue breastfeeding if their breastfeeding is protected, promoted, and supported. But there is a gap in, as I can see in the NFHS data. Look at the gender gap. NFHS shows that while 90% of the pregnant women, they got advice to breastfeed during their pregnancy. In comparison to that, only 60% of the father could recall that someone has explained them the benefit of breastfeeding. So this gap need to be broken. This gap need to be minimized. As far as the behavioral science and the messaging is concerned, ideally all these messages need to be uniform, need to be standardized, and they need to be saturated in the entire community in a 360-degree approach. But if you ask the benefit of breastfeeding, the ANM, the ASA, the Anganwadi worker, and finally the doctor, they have 5-6 different narrative around it, and the mother and the parents are getting confused. The best behavioral messaging follows the principle of EAST, that it should be easy, it should be acceptable, it should be social, and it should be timely. If you can ensure this messaging technique, then obviously it can be beneficial. In our program, we found that there is a lack of attitude and involvement of husbands in the breastfeeding issues, and this involvement is very low with a low age of children. Say for example, a child with less than 6 months, the father's engagement seem to be little lower, and then this involvement is gradually increasing with the increasing age of the child. So how can we make them comfortable in handling the child and in supporting the breastfeeding issues that the mother needs is also important. So this agency and leadership building at the community level does pay off, if you ask me.
Thank you. Thank you. I think you touched
Thank
very
you.
important point that involving uh, the people who have got say in the family, the spouse or the grandparents, and they generally motivate the mom also, the young mom who has just delivered. So that counseling or when the is done in the postnatal ward, they should be also the part of the discussion, whether, as you mentioned or Nigel also touched upon, in the continuum right from the antenatal period and at the time when the mother stays and continuing it. uh, I think we have exceeded the time, and there is another session which is there. We have got the key messages, and I know it's Dr. Sheila. The session can go on because a lot of important information is coming from all the experts. Uh, I would now hand over the to my chairperson, Dr. Hemlata, for the any closing comments if she wants to give it before, because we have got then state experience also which we need to discuss. So over to you, Madam Dr.
And
Hemlata.
Dr. Harish, thank you so much. You conducted it so well, so well. Congratulations. And very important points have come out. I mean, inclusion of private sector, which is definitely not addressed. It's a huge sector, and if we include that sector in the breastfeeding policy, it will make a lot of changes. And Dr. Arun has got this important point into discussion. And we also had Dr. Kumada telling about visiting policy of mothers, which is again a very critical thing. And about Dr. Aarti, skin to skin care providing policy also, I mean, and demand generation are very important points. And because of want of time, I would like to wind up here and thank all the panelists and also my co-chair profusely for having this wonderful discussion. Even I had to learn a lot from this discussion. Thank you very much.
Thank you, Dr. Sheila, and my co-chair, Dr. Hemlata. It has been an opportunity for us to share the experience from each other, and Dr. Sheila giving the opportunity to us to chair this important session. Over to you, Madam.
Thank you.
Thank you so much, Dr. Hemalata and Dr. Harish, and so for ably conducting this very important session. Thanks a lot. So now we are going to the next presentations, that is the presentations on the state experience. There is the roadmap for improving early initiation of breastfeeding. So here we have with us our Joint Secretary, Dr. Priyashul Babu sir, as a chairperson. So over to you, sir. So we can see. Yes, sir.
Just 1 second. ASMD madam would like to give her input. Just 1 second before starting.
I would just like to thank the all the participants of this first session, especially the chair, Dr. Hemlata, Director NIN, and the co-chair, Dr. Harish Chelani, the participants, Dr. Aarti Maria, Dr. Nigel Rollins, for his very informative and educative presentation. And I think I just want to wind up. I think it was very interesting learnings that have come from actual practical experiences. So what Dr. Maria said about how establishing certain practices is a very long drawn iterative process. It is easier said than done. These are things after constant iteration, even at her level in a facility like RML, has been very difficult to establish. And I think it is still work in progress. There must have been there must be something that is already institutionalized. So I was just discussing with the JS here, we need to have some practical guides for the people, for our workers in the field, the nurses and the doctors who are doing deliveries in the field, and especially in the public health facilities. If you could create some some nice communication, audio visual communication material, which are these just like short clips which can be disseminated, and because it will be for internal consumption, but they need to be made with carefully, with lot of respectful kind of how you need to picturize this entire process of skin to skin contact, initiating, what are the challenges. So if that could be converted into some sort of short AV material, we could also use animation. That is a very nice tool which we can, an animated kind of a simulation of what goes on. What are the do's and the don'ts? So if that could be worked out, I mean, if this group can help in the development of that material, that will be very useful. So I would request both Dr. Harish Chelani and Dr. Hemlata, if they can, work on this, and with our support, we are obviously there, and we would work closely with you. You can take Dr. Aarti Maria, her time permitting, and the other experts who are here, and help us with that communication material. And you talked about dissemination and creating this policy kind of a framework. So that point is well taken, that policy on breastfeeding should also include this skin to skin contact and all these interventions if they are not already there. So we need to look at that, Dr. Sheila Dev, and we would want that to be refined in course of the next couple of months, and definitely some communication material which can directly be shared at all our delivery points in the course of our training, using SMS, WhatsApp, that kind of technology. We don't need to create any different digital hub for it or anything. There are a lot of media available now, and we need to create innovative media for communication for our workers. So, and it's possible, it has been done in other programs. So you can integrate 2-3 activities which are closely related with supporting the mother and the child in taking that decision, as well as the health worker as to what she needs to do, the do's and don'ts. So that's all, and I would like to thank everybody for this session. I would now hand over to Ashok to take forward the next session. Thank you.
Ma'am, I just
Thank you, ma'am.
wanted to
Thanks.
say, sorry.
Yes, Dr. Maria.
I just wanted to say we already have developed a lot of material, and I would be very happy to share it. And if it could get a visibility at the national level for a positive use, it will be really good. So I would
Thank you so
definitely
much.
share. Thank you so much.
Dr.
Thank you so
Chelani,
much,
I
madam.
say something.
Yeah.
Dr. Chelani.
Yes,
Yeah.
Nigel, you were saying something. I thought Nigel has raised the hand.
Yeah.
Nigel, you want to come in?
So I was just saying thanks for such a great session, actually. That was all. But thank you very much indeed.
Yeah.
Thank you.
And thank you, madam. As you mentioned that we are going to have the messages so that they are written in the simple way. And ma'am, I just wanted to say that now the WHO is revising the guideline that start the KMC as early as possible, even for small and sick babies. So next month they would be released. Yeah. So that also will come into the guidelines so that, we can incorporate them and tell them there are many babies who are not very sick, who are not critically sick, and they can be with the mom, and the express milk can be started in them early. So I think we will sit our group actually along with Dr. Sheila Dev, and we will come out and share with you, ma'am.
Thank you. I'd really appreciate. We really appreciate that. Thank you.
Thank you, ma'am. Yeah.
Thank you. Thank you, ma'am. And ma'am, there is one question is there in the chat box. Whether you take that question or we'll take it afterwards.
Yeah, go ahead. We are all there. I mean, there are other experts. If I can't answer, somebody else would.
Yes, yes. So, sir, there is a question that in case of C-section, breastfeeding within 1 hour, it is delayed by 2 to 3 days. What should be the solution? So this is the question.
Is there an answer? That's an answer for the experts, the doctors who are doing these surgeries. Can somebody respond?
Dr. Aarti, you want to say that or shall I come in?
So sorry, I missed the question, madam. I'm so sorry, I missed the question.
So the question is that in case of C-section, breastfeeding within 1 hour is delayed by 2 to 3 days. That is, early initiation is delayed. That is not possible, and it is delayed by 2 to 3 days. The starting of breastfeeding. So what should be the solution?
Ma'am, so the answer is very simple, that we need to understand this is a life-saving strategy. Just like a CPR is essential if the patient is dying, if we consider that with a mindset, this needs to be understood by one and all. then we will consider this as an urgent priority. It has to be prioritized rather than thinking that if it is not feasible, we have to first get it out of our mind that this is not feasible. Why not it is feasible? That is for us to work out, provide clear implementation guidelines and make them happen. And that's why I said a leader, political will and right policy from the top. It has to understand, and of course we need to work out solutions and then provide to the people. I don't see any reason. That's why I'm saying we've really worked hard on it and we have made it possible. Of course, there are a lot of logistic issues that need to be sorted out, but that's for us to do it before we advise people and give guidelines that they need to be followed. But certainly, I don't buy that idea that it is not feasible after surgery. 100%.
So I think that brings us back to that issue that a small technical group comprising of people who are there in this panel can make a very clear-cut advisory on the do's and the don'ts. If it is a cesarean under general anesthesia, what can be done? If it is a cesarean with a spinal thing which is not does not put the mother in a stupor for, say, a long time, what needs to be done? And then in, of course, normal deliveries, or if there are some complications with the child, what do you need to do? So maybe if you could have those very clear advisories, and also this audio visual aid on how it is being done, so it gets normalized. People know that this is, see, nothing is more impactful than seeing it actually happen.
Absolutely.
And how do we percolate? We are a huge country. There is a huge number of points
Cultural
that we are
variations.
talking about right
Yeah.
now. So how do we do it? We can always have it converted in different languages once the material and the content is ready. So
But
that's
ma'am,
how.
I may just want to add, in fact, the simple things, simple sounding things are actually most difficult to implement. So needless to say, this comes at a cost of our understanding that we need to have operational, things circumvented, problems circumvented. Like we need either allowance of a birth companion, which again has its logistic issues because overcrowding of the labor rooms, loss of privacy to the mothers delivering, or we have to have designated, duties for the people who are available. Because right now we tell the nurse who is there, I'm not saying that we have employed newer nurses or something. It's not possible. It's not cost effective. But if we have designated roles, this should transcend the bounds of interdepartmental. The OBG people do not have to think that this is not their responsibility. So if that kind of, advisories come from the top, I'm sure we can make a headway.
So,
Thank you so
see, I
much.
was saying, ma'am, just I want to add actually to what Dr. Aarti was mentioning. Ma'am, it is there in the guideline that it has to be started even for babies who are born by cesarean section. But I think there is an apprehension in the minds of our own healthcare provider. So all those stakeholders which are involved, whether the obstetrician, pediatrician, or even the anesthetist group, those are the people who they say, okay, now the procedure is going on, has to be asepsis. Once they have the meeting of togetherness and they take a conscious decision, and once it is shown that it is in the policy, then I think it would be sorted out. It has to be done at the facility. Initially, there will be some reservation from our own healthcare provider, but these things can be easily ironed out. Over, ma'am.
Can I add a word?
Yes, doctor.
Yes.
Yeah, I just wanted to add on to agree with what you're all saying about cesarean section. But I think one of the key element here is missing point is the competence and the skills to help that. And we are missing the nursing part, and the nurses could be in the maternity ward. All the nurses and the resident doctor, they should be skilled enough to help a woman to start breastfeeding. And preparation during pregnancy is very critical for preparing women who are actually delivering babies by cesarean section. So competence by the skill set, I think, is a very, very important point, which I suggested in my earlier remark, that the current training program does not do that well. We can just change in the same hours can be used for a skill development training. Okay, over.
Oh.
Okay, so thank you all. Dr. Chelani again, and all the panelists, Dr. Aarti Maria, Dr. Gupta. And so now we are going to the next session. So under the chairpersonship of our Joint Secretary RCH, sir. We are starting the state presentations. So here, sir, we have the 6 states with us. The states Madhya Pradesh, Punjab, Delhi, and Meghalaya, Andhra Pradesh, and UT Chandigarh. So I will request first the state of Madhya Pradesh. Dr. Himani Jadhav is there from Madhya Pradesh. Can you please upload your presentation? Yes.
Hello, ma'am. Dr. Himani has been called for some urgent work. Can her presentation be taken after the next stage?
Okay. Okay. So in that case, would I request Dr. Inderdeep Kaur from the state of Punjab to come in for the
Yes, ma'am.
presentation?
Yes, ma'am. We'll just share the presentation.
Yes. Thank you.
Ma'am, we actually need to make us a co-host because we are not able to share the presentation, ma'am. Just
So in that case, can we upload the presentation from here and you just go on presenting? Screen kar do. So is the presentation audible? Is the presentation visible? Can you see the slides? First slide. Dr. Kaur?
yes, ma'am. Ma'am, is my slide visible now, ma'am? We are starting to share, ma'am. Are the slides visible, ma'am?
Okay, yes. Slide is visible.
Right, ma'am. So first of all, I would like to thank you, ma'am, and I would like to thank the respected ASNMD, ma'am, JSRCH, sir, Dr. Sheila Dev, our mission director, Dr. Abhinav, our deputy director, Director Family Welfare, Madam Dr. Vindapal has joined today. And I'm really thankful that we have you have given us the opportunity to present today for the state at the national level, ma'am. I heard a lot during this first session from the experts, and I hope we will take the cues from that and further improve. Although, ma'am, these are the indicators. We have started improving our breastfeeding indicators. As per the NFHS 4 and 5 data comparison, ma'am, we have here, like in NFHS 4 data, Punjab was doing early initiation of breastfeeding was 30.7% in total. And it was better in a rural setup, 31.6% than the urban setup. And in NFHS 5 data, we have improved by about more than 20 points, up to 53.1%. Urban, still it is lesser than the rural, where it is 53.5%. However, we have not made much improvements in the children under 6 months who are exclusively breastfed. That is from 53% to 55.5%. I think we need to focus a lot. Although improvement is a little better, but there is a long way to go, and we have to improve the things, ma'am. Next. So various strategies have been adopted at the state level for the improvement of the strengthening the infrastructure, for improving the capacity building. Number one was the infrastructure, ma'am. State is boasting to have a total of 45 MCH wings by the end of 2024. At present, we have around 32 fully functional MCH wings who are dedicated and providing a quality maternal and child health services 24/7. And as per facility-based newborn care, we are having 24 SNCUs. Out of these, 22 are in our district hospitals and 3 SNCUs are based in our 3 government medical colleges. And we have 56 NBSUs and 208 NBCC, that is newborn care corner, at almost all the delivery points in the state that we are having. Another new activity has been approved, and I'm thankful to Ministry for approving this in ROP of 2022-24, that one mother newborn care unit at Guru Gobind Singh Medical College and Hospital Freeport has been approved, and 3. Ma'am, I'm audible?
Sorry. Yes, your slide is not moving, Dr. Kaur, from as we can see. Is it
moving, ma'am? Is it visible, ma'am?
It is not. It's the first slide. It is the first slide only. that we can see from here?
I'll just check, ma'am.
Can you please keep it in the slides sharing mode in the
Yes,
presentation?
ma'am.
Yes.
Is it visible now, ma'am?
It's not moving. It's visible but not moving. आप यहाँ से नहीं कर सकते हैं Okay, madam, Dr. Kaur, you can stop sharing and then we can upload it from our side.
Right,
Okay?
ma'am.
So please
Yes,
stop
ma'am,
sharing.
kindly.
Yes.
Right,
Yes.
We are not sharing now, ma'am. You can share the slides.
So just go on speak like next, and then we'll be doing from our side. Okay.
Right, ma'am.
Okay, madam. Yes. Now it is. We can.
Next, please.
Next.
Yes, ma'am, this data has been discussed already that there is an improvement from 30.7% to 50%. And ma'am, this is the main, we are focusing on strengthening the infrastructure. I mean, mother and child hospitals I've already discussed, ma'am. We have almost total of 32 functional. Next, please. Yes, thank you. We have total of 32 functional MCH wings, ma'am, and 6 are in the process of building up. And as I have already previously told that our mother newborn care unit, and we have 2 aspirational districts, Firozpur and Moga, and 3 NBSUs, new NBSUs have been proposed, 2 at Firozpur and 1 at Moga, because the indicators are poor in those aspirational districts. So our focus is on improving these indicators of child health on in these districts, ma'am. Then these are the various glimpses from the capacity building at the state and district level for the child health program. Our district immunization officers are the nodal officers for all the child health programs, ma'am. Our director family welfare, madam, is addressing this district immunization officers meeting. And ma'am, all the meetings and all the capacity building trainings are focused, they are with the focused approach on the level of the training. I mean, for the ASHA, we are giving in a more vernacular way. We are involving the local SMOs and local medical officers at their place. So it is an easily understandable. The points that has been discussed, that the modules have to be different for the medical officers and for the ANM and ASHA, because the capacity building levels and understanding levels definitely, ma'am, differ. And we are totally focusing on till the grassroots level. Next, please. So, ma'am, the changes were also made in the regular setup. Now, almost all the district hospitals, we have the breastfeeding corners, and slowly we are going to saturate them down till all the MCH wings and till all the subdivisional hospitals. Because even in the first picture I'm showing is our head office. In our head office, where our staff nurses would come for the transfers and other administrative work, they would have small babies, and there was a need felt that the women needs to have a privacy. The women needs to have a privacy for breastfeeding the child. So there is a dedicated breastfeeding corners, and we are making it in many of our offices also, and in almost all the district hospitals it is there now. And next, please. Now the breastfeeding policy, it was launched in the state on the 1st August 2022 itself, on when we were starting the breastfeeding week celebrations. And this is Principal Medical College, Mohali, Dr. Bhavneet Bhati, who's a pediatrician herself, along with the Deputy Director and myself, ma'am. We are having a breastfeeding policy in the state, and breastfeeding policy is very important because it is going to emulate all the good practices to make all the hospitals who are Lakshya certified, they should also be a baby friendly hospitals. And this is first step towards that initiative. And we will be helping to implement all this policy in at least all our Lakshya certified facilities. DH and STH, till STH level, we have taken the target for the Lakshya certified facilities. So we actually plan to make them the baby friendly hospitals also. Next slide, please. These are various awareness programs, ma'am, among the various pregnant women we are using. This is the glimpses of the family participatory care that is implemented in all the SNCUs. Here we have the audiovisual aids, which are focusing on the importance of breastfeeding, which are focusing on all the parameters of child health, actually infection control protocols and everything. And it includes the breastfeeding as an important aspect of this family participatory care. So we are implementing it with the use of audiovisual medium at all the health facilities. Next, please. Now, various IEC activities have been planned during this week, ma'am. And these include, next, please. These include, ma'am, print media, they include the audiovisual media, they include, we had a radio talk at the Doordarshan also by our Director Family Welfare, and poster competitions are there. And we have the support of our medical colleges, all the three HODs who are pediatricians. They are also, ma'am, supporting us for these initiatives. The poster competitions are being organized, and the message is very clear down the lane till the grassroots level that the celebration is not only for this week or this month. It has to be a continuous process because we have to improve the indicators. Yes, ma'am, I would like to also add on the comment that one part is that we are having around 48% delivery in the private sector, and cesarean section rates in Punjab are high. They are at 36.8% as per NFHS 5 data. That is really a cause of concern, and we will try to focus on how to start early initiation of breastfeeding in the cesarean section mothers. It is going to be a challenge in the private sector since there is no clinical establishment act in the state. So it is going to be a challenge, but we will try to do our best, ma'am. Next slide, please. These are all the glimpses from the IC activities, ma'am.
Sorry to interrupt you, Dr. Kaur. Actually,
Yes,
we are actually running late. So can you please?
That is all, ma'am. That is just the few launches only. That is all. I'm winding off, ma'am. And thank you for your support always, ma'am. And that is all.
Thank you so much. Thank you so much, Dr. Kaur, for a very nice presentation. And so I request all the other rest of the representatives from the states to be brief, and but because we have only around 5 minutes time for the speaker. So next I will next I will request the state of MP, Dr. Himani. Can you please present now? Thank you, Dr. Kaur. Yes.
Yes, ma'am. Thank you so much. Just a minute, ma'am. We'll be uploading our. No, we cannot share the content. Ma'am, we are unable to share the content. So, from our end.
Okay, from our side, we are doing this.
Sure, ma'am.
Okay.
Thank you so much. Good afternoon, everyone. I really appreciate that we are focusing on such an important aspect of IFSCF, and moreover, we are also promoting the breastfeeding in our system. So moving ahead, I would just like to apprise on to few factors. I mean, can we move ahead with the PPT, please? Yes, next. So Madhya Pradesh, as far as our progress is concerned, it is very evident from the progress that Madhya Pradesh has from NFHS 4 to NFHS 5, where we had a 15.4% decline in the nutritional current scenario. Then moving ahead, if we go again, looking into the aspect of, ma'am, can we have the next slide, please? If we move on to our early initiation of breastfeeding, so if we look at the data from NFHS 4 to NFHS 5, there has been an increase by 6.9%. Then moving ahead, this is the overall scenario that Madhya Pradesh is persistently working on two factors. One is early initiation of breastfeeding. The another aspect is exclusive breastfeeding. When we talk about the, can we move ahead in the slides? We are done with these slides. Can we come on to the fourth slide? Next slide, please. We just wrap up. We won't get into this. Next slide, please. Ma'am, we are not covering where we stand in the state or where, but some points that we wanted to highlight was that we have a 15.4% decline in under 5 mortality rate. There is a persistent decline in the undernutrition, stunting, underweight, and wasting cases which are being reported. We are among the top 10 states where we have shown an improvement in the early initiation of breastfeeding rate. And out of every 100 children, 9 children in Madhya Pradesh receive an adequate diet. So if we move ahead looking onto the scenario of what exactly MP is doing during this commemoration of the World Breastfeeding Week, and what are our further line of action and our way forward. So I would just like to apprise through the glimpses of the few activities that are being done in the state, that are being continuously being monitored from the center. So can we move ahead in the slides? Next slide, please. Yes, I mean the slide before this. On it. So for the facility-based initiatives, the photographs that we have kept here is that there is a continuous dedicated counseling sessions going on in the postnatal wards, where the mothers are being taught about the benefits of breastfeeding and the IVF practices through the staff nurses and feeding demonstrators. Through our two CLMCs which are currently functioning in the state, the mothers are being supported for donation of milk. Then there is dedicated counseling for the antenatal mothers in the antenatal clinics, so that during the process of the labor in the labor room itself, the early initiation of breastfeeding can be promoted, can be taken care of. And also the mothers who undergo C-section, they are being continuously supported for breastfeeding. We currently, I would just like to apprise our audience that in Madhya Pradesh, as the discussions were earlier also going on in respect to the creation of the infrastructure for the child health, we currently have 150 NBSUs functional across the state, out of total 343 which were proposed last year. By end of December 2023, we'll be having 343 NBSUs practically covering each and every block of our state. Secondly, we have 15 NHDUs, which are or MNCUs as per the new nomenclature, which are currently functional, and we have another 9 to be made functional by the end of this year. Then we have 1577 delivery points where we have ensured that the breastfeeding corners are established so that the mothers can be supported while they're in the hospital, so that they can practice breastfeeding their child and can be motivated for exclusive breastfeeding. So moving ahead again, after the facility-based initiatives, if we talk about the next slide, please. Next slide. These are a few of the facility level initiatives that are being focus group counselings. Then we have one-on-one counseling by the feeding demonstrators in our NRCs to the mothers or the children who are identified with malnourishment under 6 months of age. And also the mothers are being supported for MMI, so that, using supplementary suckling technique, they can be handheld for the feeding of their children and can have independent and comfortable approach in feeding their child. Next slide, please. Next slide, please. So as far as They've skipped the slide, I believe. Okay. So as far as the strategy for improving the IVF rates, at the part of community level intervention, I'm glad to inform everybody that Dastak Abhiyan is one Abhiyan in our state which is being run since 2016, which is a month-long activity where we have a focus all towards the child health initiative where we can we get back to this slide? So where we focus on the childhood illnesses, their identification, and also we also emphasize on the counseling of the families and also the counseling where we basically look into the enhancement of the core skills of all our frontline workers and all our the primary caregivers from our system as well as the primary caregiver as which is mother or any other family member. The approach in Dastak Abhiyan this year has completely been focused towards family participatory care. Last year when Dastak Abhiyan though was conducted during the hard times of COVID-19 epidemic, still we could manage to reach up to 25.72 lakh households where the mothers were counseled for IVCF. This year, there has been 12 days there when we have started with the Dastak Abhiyan and we have already reached 2.85 lakh households. The photographs here are depicting various activities conducted by our frontline workers during the complete phase of the Dastak Abhiyan. Can we move on to the next slide, please?
Yes, madam. We're doing that, but again, I'm requesting you, please, madam, be brief because we have time constraint.
Sure, ma'am. Just we want to apprise you for one thing. I would just take 30 seconds.
Next slide.
Ma'am, there was one initiative that we have taken up during this year is identifying in the first phase all our Lakshya certified facilities as breastfeeding friendly facilities. So taking the all 10 points recommended by WHO for making a facility which is a breastfeeding friendly facility, we'll be certifying. A DO letter has been issued to all the district magistrate across the state by our MD NHM, where she has already informed them, and we have started even disseminating the same to our facility in charge. So this is one facility, one initiative that our state has taken up so that we can have improvement in our statistics as well as in the practice for promoting IVCF throughout the state. Thank you so much, ma'am.
Thank you, Dr. Himani. Very elaborate presentation. So we are going to the next state now. The State Neonatal Officer of Delhi, Dr. Anuja Prakash. So we are, without wasting time, we are uploading the your presentation from our side. Okay. So are you there, Dr. Anuja?
Yes, ma'am.
Yes.
Yeah, good afternoon.
Thank you for being
Yeah,
here.
good
Yes.
afternoon to ma'am and good afternoon to JS sir and ASMD sir. Thank you all for letting me present on the behalf of Directorate of Family Welfare in Delhi this small presentation. Can I have the slides, please?
Yes, we are uploading that. Yes. So is it visible?
No, it's not visible. It's not visible. Yes, it is visible now.
Yes.
Yeah.
We may start now, please.
Yeah. It is just an introduction to all the breastfeeding practices which is going on in Delhi, and especially how we have improved in our NFHS data. So we follow what WHO recommends, that all mothers should be supported to initiate breastfeeding as soon as possible after birth within the first hour after delivery. Next slide. So if we look at the Delhi scenario, as per NFHS 4 and NFHS 5, our breastfeeding percentage within 1 hour of birth has improved from almost 28.6 to 51%, and our exclusively breastfeeding percentage has improved from almost 49.6 to 64% for Delhi. But if you look into our comparative data, which we have in our HMIS, where our public health facilities and some of the private health facilities are reporting, it is from 2017-18 till date, it is between 67 to 74%. And we are trying all our efforts to further improve it. Next slide. The initiatives which we have taken at the state level, we have concentrated on IYCF training. Till now, we have trained around 1342 medical officers and nursing staff in the state who are IYCF certified trained. Then in our Daksh training also, around 1406 medical officers and nursing staff have been trained, and with emphasis on breastfeeding practices. In our community level initiatives for the training, we use flip charts for counseling of mothers during the mothers meeting under MA program. Then 95% of our Ashas of Delhi are already trained in Module 6, and they are utilizing this in their mothers meeting. Then we have our monthly Asha refresher trainings at the healthcare facilities, where emphasis is given on breastfeeding practices, and they are asked to utilize this and counsel the mothers during their HBNC visits. Next. What happened was, when we identified our facilities initially, where we had the low breastfeeding rate, and those facilities and hospitals then did a process flow mapping. In their process flow mapping, they identified what were the gaps which was there in the hospitals. After a gap analysis through a root cause analysis or a fishbone analysis, they planned how the gaps can be moved, how the gaps can be covered, and targeted interventions were planned in the hospitals. And accordingly, the percentage was then improved. At community level, we ensured that there was a thorough implementation of the MA program through our counseling practices by our ANMs and ASHAs. Next slide. The activities which were carried out after the analysis at the facility level was, they have now they all have a written breastfeeding policy, which was communicated to all the health staff. We have started regular counseling about breastfeeding in antenatal clinics by ANMs and staff nurses, not only in the hospitals, but also in our primary healthcare facilities. Then periodic sensitization is being carried out of MO staff nurses and all the staff which are posted in labor room, OT, SNCU, and ICU step down, and even at the PNC wards. Then we have initiated skin-to-skin contact for at least 1 hour after birth, even for the babies post-cesarean section. There is early rooming in, which has been started. Then we also encourage mothers in the hospitals to help each other to breastfeed the baby. Next. We have also ensured sensitization of the mothers by all our nursing staff. Then they support the mothers to recognize and respond to their infanting feeding cues. Pre-lactal feeds and provisions of pacifiers and teats are completely avoided in the hospitals. All foods and drinks are restricted in the newborns unless medically indicated. Then there is a continuous audiovisual messaging which is going on in OPT nursery, our postnatal wards, KMC wards, about the breastfeeding practices, about early initiation, skin-to-skin contact. We educate the mothers how to, in regarding the expressing the breast milk for sick babies also. So after our analysis, we have also come to it that by keeping a record of all the delivered babies in our labor room register, just to ensure that when the baby leaves the labor room, the baby has to be breastfed, has helped. Then documentation of breastfeeding in our postnatal round register has also helped. Then our IYCF centers are there in all our hospitals, where we have a IYCF room where we counsel the mothers with the doll, breast model, flip chart, and the flashcards. Then mothers which are having difficulties, who all face difficulties in breastfeeding, are counseled by using breastfeeding techniques and tools by our IYCF trained staff. Then we also, in the IYCF centers, we also counsel the primary support cares of the primary support care of the mothers, that is the father and the grandmother. Next slide. We have started involving the private sector. We are carrying out sensitization and awareness activities amongst our private practitioners by involving the IAP, NNFI, IMA, and DMA. Next slide. So at community level, the activities which we are carrying out is mothers meeting by Ashas. We can see it from the trend that there is an increasing trend for Delhi since 2018-19. Our mother meetings have also increased. Our participation in the mother meetings, which is almost crossed 2.5 lakhs, has also increased. The pregnant women who have been participating in the mother meeting and the lactating mothers has also increased. We have a UHND sessions conducted by our ANMs in the Anganwadi workers or in the outreach areas. There also we give a session on emphasis on breastfeeding. Then during the HbA1c visits, which is conducted by ASHAs, an emphasis on breastfeeding is being done. Next slide. So what changes we made in the
So,
regular?
madam, sorry to again interrupt again and again, but this is a sincere request. Please keep
Yes, ma'am, I'm just done.
so because of the time constraint. Okay.
Yeah, ma'am.
Okay.
Yeah, ma'am. So the changes which we have done is we have now ensured that there is a dedicated breast feeding room or space in the nursery, in the OPD, and in all our primary healthcare facilities. We have our NICU being remodeled to include a separate cubicle with beds and seating for breastfeeding in district hospitals. Then we have also ensured there is a facility for storage of expressed breast milk in our SNCUs and NICUs. Next slide. So this is the IEC because in our PDCA cycles and in our analysis, we have found that the position and latching of the breast was missing amongst. So we have a special IEC has been put up in the hospitals to explain the mothers the position of breastfeeding and the latching methods, and also our benefits of breastfeeding. Next slide. Then this is the IEC which we are doing. We have done a mass media through our mass media through newspapers in the advertisement in the newspapers. Then we have also taken a pledge by all the SPOs with the, under Chairmanship Directorate DFW to promote breastfeeding. We have printed messages of breastfeeding on our OPD slips. Then there are focus group discussions with the ASHAs which are going on and has been carried out. We have been carrying it out. Poster and slogan making competition, Munadi, Nukkad Nataks, then healthy baby shows are being organized. A visit this is a new thing which we have started. We've taken our ASHAs to visit the nearby hospitals for demonstration of breastfeeding practices. Next slide. Then we have also started social media sharing to cover all the elite class about all the activities which is happening through our DFW handle of Twitter and Facebook, and all the messages about awareness on breastfeeding. Next. So we should all start thinking that how and the ways what will we all do to protect, promote, and support breastfeeding. Thank you so much.
Yes. So next we are thank you, Dr. Anuja. So now we are requesting the state of Andhra Pradesh to make the presentation. So we have already uploaded your presentation. Are you there? Dr. Arjuna is there? We are not being able to hear you. Unmute me, mute है क्या?
Ma'am, are you able to hear me?
Yes. Yes, now we are being able to hear you.
Yeah. Next, please, ma'am. Next slide, please.
Next slide. Next slide.
In the state of Andhra Pradesh, the state of Andhra Pradesh, the emphasize the early and the immediate breastfeeding, all delivery points and the institutionalized through program like MA and IFS and Laksha programs. The previous breastfeeding, early breastfeeding is rise from NFHS 4 to 5 is the 12%. The NFHS 4 is
You are not audible actually.
yeah, madam. In the NFHS 4, only 40% of the early breastfeeding, that is the NFHS 5 is 52%, the rise is 4%. But in the exclusive breastfeeding up to 6 months, that is a decline, the 2.2% from the belong to the state concerned. We are practicing all the institutions practicing early initiation of breastfeeding in the routine programs in the SNGUs as well as all delivery points of the newborns. And we are messaging exclusive and continuous breastfeeding giving during home visit by the ASHA and ANM in HPC, and especially in Andhra Pradesh, we are practicing ANM app, digital app that is mandatory visit by the HPNC program, and they are supposed to ensure the continuous breastfeeding and complementary feeding also. They are supposed to ensure the data into the portal. Next one is the participatory care parents and the family members. The newborns were entered among important exclusive continuous breeding at SNGUs and as well as NICUs. We are practicing in everywhere in the SNGUs. There are 50 of SNGUs. In 27 is the regular, and we are practicing in public-private mode in many SNGUs like in tribal areas. And further strengthening of breastfeeding, we are planning to CLMSs in every district, that is the 13 districts in this year. Next one is that we are coordinating with the health and well ICDS department and as well as the health department. So we are coordinating with each other and strengthening of the awareness to the pregnant mothers and as well as postnatal mothers to ensure early breastfeeding as well as continuous exclusive breastfeeding and complementary feeding also. Next, please. We are planning to build the environment, the respectful maternity care for the every pregnant mother in all the healthcare facilities like SNCUs and NBACUs and NRCs also. That is one thing. And next one is the capacity building for the frontline workers, those who are participating at the community level by the ANMs and ASHA and Anganwadi worker to ensure breastfeeding, early breastfeeding and exclusive breastfeeding, as well as meeting with the VHNDs and as well as group meetings by the Anganwadi centers also, ma'am. Next one is the focusing further improving the initiation of breastfeeding among newborn deliveries. We are sensitizing all the delivery points, those who are attending at the OTs and as well as delivery points to ensure the early breastfeeding. And regular monitoring at the district level by the DIOs and as well as state officials to ensure to increase the next year more than 20% of existed early breastfeeding activity. This is my side. Thank you, ma'am.
Yes. So, thank you very much, Dr. Arjuna. So, we are going to the next stage now. So, we are going to I'm requesting the Chandigarh, Dr. Bandana Mohan, to please present on behalf of Chandigarh. So we are uploading the presentation on your behalf, madam.
Can I start, ma'am, with your permission?
So can you start, madam? Dr. Bandana Mohan ji. So on behalf of Dr. Bandana Mohan, we think that Dr. Sadbhavna is presenting. So, madam, we are not audible. Madam, we are not audible. Can we go to the next state in that case? So I would request Dr. P. Manners From the state of Meghalaya. Acha. Ma'am, we are not being able to hear you. Madam. कोई सुनाई नहीं दे रहा. Madam, I would request you to please come after Meghalaya. Huh? Madam, there is some issue in your sound system, maybe. We are not being able to hear you, madam. So, madam, in that case, as we be able to hear you, madam, kindly look into if there is any problem in your sound system. And in the meantime, we can go to the next state, Meghalaya. And after Meghalaya, madam, you may come again. So we are, is Dr. Manners is there? Dr. Manners, are you there from Meghalaya? Is there anyone from Meghalaya? Hmm?
Okay. Okay. Yes, ma'am. I'm Dr. P. Manas, Nodal Officer, Child Health from Meghalaya.
Yes,
And
welcome, Dr. Manas.
okay, yes. First of all, I would like to thank Madam Ruli Singh, SMD, and also Sir Ashok and you, Madam Sila, for giving us this opportunity to share a presentation in this very important platform. So next slide.
Next.
Okay, so let's look at the IMR status of Meghalaya and India. So when we look at this picture, this is the data from SRS 3 2020. And when we look at this data, we can see that there is, a declining trend of IMR from 2003 2005. But from 2005 2009, there is a increasing trend again. But from 2009 till date, there is a slow decline trend in the MR. Currently, we are at par with the national MR average, that is 29, in which India is 28. Next slide, please. So this is the picture which shows the data of the early initiation of breastfeeding within 1 hour, and also in comparison with the low birth weight. So looking at this correlation of breastfeeding within first hour with the low birth weight units, we can see that there is an inverse relationship. So, but here during this campaign, during this World Breastfeeding Week, we are going to concentrate on this low birth weight. So we'll convince the mother to come forward to breastfeed the children, even if they are low birth weight, because this is a very important part. Next slide. So this picture will show us why you want to promote breastfeeding. So when we look at the adequate diet received 6 to 23 months during NFS3 and 5 to 6, we can see that we NHS 5, the children receive.
Madam, just one second. I'm interrupting. I'm very sorry. So, madam, I understand there's a very good presentation you have prepared. So, please, I will request you to please show us the important slides. The presentation will be with us because we have the next meeting on 2 o'clock only.
Okay, next slide then. Next slide, ma'am.
Yes. Okay, thank you.
Next slide, please. Okay, so World Breastfeeding Week 2022 in Meghalaya. We have started since the 1st of August and it's still to 8th of August because 7th falls on Sunday. And the theme is Step Up for Breastfeeding, Educate and Support. And these are the area where we focus. One is initiation of breastfeeding in 1 hour. Of course, we are doing very well in this, but when we come to exclusive breastfeeding again, we have to sustain this because we are at 43% only based on NFSS 5, and also continue breastfeeding up to 2 years of age or beyond, and strengthening complementary feeding and infant young child feeding, because we still have lots of malnutrition is a challenge in Meghalaya, so we are going to strengthen this. And all district hospitals, CACs, PACs, state dispensary PACs centers should be breastfeeding friendly healthcare facilities, and also would like to ensure breastfeeding supportive communities, and also to ensure and promote breastfeeding friendly spaces in workplaces. This is both for government and private. So the objectives of, as we know that this SDG also, they have the main objective of SDG is to achieve single digit IMR. So to achieve this, we know that it's important for exclusive breastfeeding to be given for the first 6 months of life, complementary food 6 months to 2 years of age, and complete nutrition of newborn and food safety and newborns, health and growth monitoring, both newborn and infant, early childhood development, mother health benefits work together to achieve the SDGs by 2030. So the strategies during this World Breastfeeding Week in Meghalaya are: one is capacity building of healthcare staff, both government and private, with support from UNICEF and IEP. This is we have already started this. This is ongoing, ma'am. This is about the benefits of breastfeeding and COVID pandemic, provision of infant milk and substitute IMS Act, and express breast milk feeding, and also kangaroo mother care, and also to ensure availability of all breastfeeding and EPM feeding accessories in postnatal ward of all health facilities, and also pregnant women, lactation women, counseling, mother absolute affection promotion. We focus on home visit of low birth weight and preterm infants, and also we ensure alternative feeding utensils in all the repoints, and also ensure accessories related to KMC in all health facilities. Next slide. The other strategies also are the convergence with IAP, FOXY professional bodies, convergence with social welfare as department, awareness generation using various means of communication, IEC activities, banners, hoardings, print media, etc., and also social media coverage and media sensitization, and women leaders engagement at community level for mothers, sensitization on breastfeeding and IYCF, implementation of infant milk and substitute in all health facilities, both government and private, display of hospital breastfeeding policy, both government and private, and also breastfeeding friendly health policies initiative in the state. And also pledge has been read by all the healthcare staff and also by the SDS department staff. Next slide. So these are the pictures which shows the activities in the state. We have the mother sensitization, the awareness program. Next. And the areas where counseling for counseling during this World Breastfeeding Week are: number one is advantages of early initiation of breastfeeding within 1 hour of birth, the importance of colostrum feeding, composition of mother's milk, positioning and attachment, frequency of breastfeeding, disadvantages of bottle feeding, exclusive breastfeeding for 6 months, breastfeeding children with low birth weight and premature babies, and also kangaroo mother care even at home, breastfeeding during and after illness, breastfeeding supportive community, expression of breast milk in special situations, and also growth monitoring and promotion, IMS Act also, and then baby friendly hospital initiative or policy. So if you, then this is another example of, this is another picture of the activity during this breastfeeding week. That is, this is one of the initiatives we are planning, ma'am. This is breastfeeding policy in offices for working women, because we know that especially in Meghalaya, we have many working women in the state who still used to breastfeed their children. So we are trying to have dedicate a private area or clean area to allow women to breastfeed their children in privacy, because this is very important for all women, especially in Meghalaya. So now we are in the process of this to give the right of breastfeeding for all the women in both private and government facilities. Next slide. Next slide, please. So breastfeeding and disaster. Infant nutrition during a disaster breastfeeding and other options. We know Meghalaya also faces some of disaster like floods, landslides, etc. So we should ensure that safe and clean space should be there during this disaster situation to ensure that every refugee camps or temporary settings should have breastfeeding area. So we want to see that during floods and other disaster, we should give the right to every woman to breastfeed her child in a privacy. The next slide, please. So COVID appropriate behavior is followed in all the activities. Next slide, ma'am. So we have done the state launching and celebration of the World Breastfeeding Week at the state. This is the picture where all the we have all the joint directors, we have the director with us, the national directors, and all the nodal officers of different programs, the different partners, and even the district MCH which we joined online. And we did the pledge, and also orientation was on that day regarding breastfeeding by the pediatrician. And this has been put in social media of all the activities. We have the Twitter, and ma'am, now it is ongoing, and we have many other activities. Next slide.
So thank you, sir, madam. I think you are at the end of your presentation. Any more slides?
Next slide. So we have these other activities,
nice
ma'am. We have this poster competition, prize distribution, and we have the quiz competition as well. And we have this awareness program, and we also have radio talk and Dodashan talk also by the renowned pediatrician of the state, ma'am. This is all from Meghalaya. Thank you, ma'am.
Thank you so much, Dr. Manners. Very nice presentation. So heartening to see initiatives you have taken at your end. So thank you. So next I'm going to the state. Thank you. And next I'm going to the state of the UT of Chandigarh. So Dr. Bandana, are you there now?
Hello. Hello. Good afternoon, ma'am.
Yes. Yes, ma'am. Now you are audible at last.
Okay. I'm audible, but I think I'm not visual. some pop-eye is occurring now and then.
No, no problem. We are able to hear you, and your presentation is there on the screen.
Yeah. I see.
Okay.
A very good afternoon to everyone, and warm greetings from Team Chandigarh. And I'm sorry, I'm very apologetic for this pop-up. So straight away, we know we have paucity of time, so I'm going to straight away talk about the contentious and the relevant issues. So going about the theme of the World Breastfeeding Week this year, we need to educate and we need to support. So at the outset, I would say that by persistent gentle persuasion and supportive supervision, we strive to sustain and further improve the breastfeeding rates in our city. So going by the data I have with me, children under 3 years of age, which have been breastfed within the first hour of birth, as per the NFHS data, is about 63%. I'm told that last NFHS data 4, we were at about 33%. So there's almost, we have doubled our achievement in this regard. Regarding children, which is like 0 to 5 months or 6 months, which has been exclusively breastfed, as per DLHS data, is about 76%. And as per our own data of HIMS, I find that number of newborns which have been breastfed within 1 hour of birth stands at about 85%. So always, I think with all states and countries, all states and UTs, this disparity about the NFHS data, the local data always remains, and these issues will have to be sorted out, and we got to believe our local records. So going by the strategies adopted for improvement, right from like it is uniform to all the guidelines which have been laid by the Government of India and by the WHO. So we are focusing on the interpersonal counseling of beneficiaries. There has been a special change in the appointment of a lactational counselor who has been exclusively posted at all the delivery points, and she is monitoring it in her early initiation of breastfeeding and exclusive breastfeeding. The sensitization of staff is occurring on a regular basis. And one very unique thing which has happened to Chandigarh that we have started is that we have been distributing certificates of appreciations to proud mothers who breastfeed their babies within 1 hour of birth. So ours, I'm Dr. Sadhavna, I'm representing the only sole district hospital, government multi-specialty hospital, and I'm heading Department of Pediatrics. So Department of Pediatrics has taken this onus of taking this away forward. So we have started special exclusive breastfeeding, some initiatives at district hospital itself. Apart from the community level activities which are being carried out to increase the rate, like promotion of breastfeeding, exclusive breastfeeding, and complementary feeding, which is being done by staff at all the health facilities of Chandigarh. We have been using even the mother-child protection card during the antenatal visits and sensitizing the health workers and the general public about the benefits of breastfeeding. Regular visits for monitoring of these activities is being done by the medical officers and by the local health staff, and even on the regular house visits, these things are being closely monitored by the staff. So the changes which we have made at the setup in our regular setup is at the main district hospital, which is our only district hospital, which is catering to almost 7,000 deliveries per year. Can you move on? Move the next slide, please. The previous one. Can I have the previous one? The one on data. I'll just quickly verbally tell you that in our hospital over the last 1 year, there were about 6,500 deliveries, out of which exclusively babies who were breastfed were about 6,300, which worked out to about 96% of the babies. So this special campaign which has been launched was during the launch of the Rashtriya Poshan Ma 2021, which was realizing the Honorable Prime Minister's vision of the Suposhit Bharat. This awareness campaign was launched, which was like initially early breastfeeding was done right on the spot on the delivery table and also in the labor room. So the skin-to-skin contact did happen, but I would agree to hear and accept with humility that the 1 hour period of the exclusive skin-to-skin contact was not really possible, and it was very difficult to keep this as a permanent feature. So this part, I think in the next year, we need to focus on, and skin-to-skin contact is actually being monitored for very uncomplicated delivery. And one thing very peculiar to our hospital is that we have a DNB program which is being run in the hospital. And this DNB program, the residents, the nursing staff, the senior nurses and the senior doctors on duty are monitoring these patients on a day-to-day basis. And daily bed-to-bed inquiry is made as a special initiative, and all the lactational problems of the mothers are addressed round the clock. Next slide, please. Out of our 7, next slide, please. Next slide, please. Next slide, please. Next. Okay. This is another, in all the postnatal and the pediatric wards and the pediatric wards and the OPD, a bottle-free feeding-free area has been carved out, and this has been strictly adhered to. Next slide, please. Maintaining the privacy of the lactating mother, special breastfeeding corners have been set up in the outpatient of our hospital. Next slide, please. So regarding the intensive IC activities, a lot has been broadcast as jingles on the importance of early initiation. Local nataks have been held at various corners of the cities for awareness generation, and proper display of banners, posters, and decision trees and breastfeeding policy is being adhered to. I would emphasize here that out of the 7 delivery points which are there, 2 are tertiary care points. One is PGI and one is GMC, which is a medical college. So they are maintaining their own policies in their own hospitals. Our under the health department, government multi-specialty hospital as well as sub-divisional hospital at Mani Majra at sector 45 and 22. These are all Lakshya certified institution, and they are realizing the dream of almost 100% breastfeeding acceptance in the first golden hour. So only the babies which are born at Sector 16 hospital, which are like sick and critical, the ones which are admitted to SNCUs are the ones who may not have been given the breastfeeding at birth. But almost I could say that out of them also, these are only about 4% which have been left out due to some reasons. So coming to the end of my presentation, I did listen to all the speakers, and it has been a great learning effort to listen to all the speakers, and there have been very important points which have been pointed out today regarding the involvement of the private sector, regarding the visiting policy, and regarding the skin-to-skin contact policy. So taking a cue from these three things which have been brought up very nicely, I would request my nodal officer, Dr. Vandana Mohan, to incorporate these policies into her next PIP. And regarding the points raised by Madam Jayaram, regarding the presence of the staff at all the time at all the corners, I think this issue has been addressed by our institution. So we have 24/7 staff working to address these problems. So thank you very much for listening to me patiently. Thank you.
Thank you very much, ma'am, for a very elaborate presentation, and what all being done in Punjab to improve the breastfeeding practices. So with this presentation, now the state presentations are complete, and so as JSR had to leave for some other important meetings, so I hereby announce that the end of this session, and really it is a very rich learnings we have accumulated after this important webinar. And so now it is my turn to propose a vote of thanks. So first of all, I would actually, it is my privilege to propose this vote of thanks on behalf of the Ministry of Health and Family Welfare. I convey my deep regards and hearty thanks to SMD ma'am and JSRCH sir for gracing this occasion and to take out their precious times to be present and guide the discussions and participate in the discussions also. And my sincere thanks to our Joint Secretary sir, and that, as I've already said, and then I am very much thankful to Professor Himalata, Director NIN, for chairing the panel discussion and guiding the session. My heartfelt gratitude to Professor Harish Chelani for his able moderation and bringing up the key messages from the panelists during the discussions held. My sincere thanks to Dr. Nigel from WHO headquarters, who has managed to adjust and take out his precious time to attend the webinar and has shared very important evidence-based technical messages on early institutional breastfeeding. I would also like to thank all the eminent panelists who participated in the panel discussion for they shared their thoughtful comments and inputs. Dr. Kumuta, Dr. Aarti, Dr. Antaryami, and Dr. Arun Gupta. Thank you all. My heartfelt thanks goes to all the state participants for their elaborate presentations. And last but not the least, I would like to thank all the participants who have actually been present throughout this session. This is a webinar session. And actually, we had more than around 250 participants at the peak hours. And so, and last but not the least, I would like to thank my own team and the ministry, Dr. Shraddha Verma and Dr. Sneha Mutteja, to be there always, along with Dr. Vishal also from Save the Children, who helped us and to make this event successful. And my special thanks to Dr. Indu Deval, who has joined newly in our in this our division, in the nutrition division, in the capacity of senior capacity of CMA and FSG, CMA SG, and she has been attending this session from Karnataka during her field visit. So thank you all. Thanks everyone. And so here I call the end of the day. Yeah. Thank you so much. Namaskar.